Okay, thank you very much, Mr. Arun. Bismillahirrahmanirrahim. Assalamualaikum and a very good afternoon to everyone. First and foremost, I would like to express my gratitude to the organizing committee, especially to MaHTAS, MMA, and our partners for inviting us here today. So my job here today is to talk on the risk factors pertaining to erectile dysfunction. So these are our learning objectives to know about the risk factors as well as protective factors for erectile dysfunction. So to begin with, we need to know what is erectile dysfunction. So erectile dysfunction is a condition which affects a guy which is not able to achieve not able to achieve erection, loss of rigidity, as well as a person which not able to sustain erection till completion of sexual intercourse, lasting beyond 6 months and causing distress to the particular poor guy. So uh, based on the latest NMHS 2019, it is said that roughly about 1 in 3 men was affected in 2019 of erectile dysfunction, and we have seen more and more EDs nowadays. So, if you look at the risk factors, there are diverse risk factors ranging from age, and we have divided the risk factors into many domains such as your lifestyle behavior, cardiovascular, metabolic, neurological, psychological, and hormonal risk. So, managing ED can be very, very tricky because the risk factors can overlap, they can gel together, and even mask one another. So, erectile dysfunction is just a complaint to you. A person will come to your GP and mention, Doctor, I have poor erection. So that is just a complaint. What is our role in primary care is to further dissect the history and as well as getting the risk factors so that we can reduce the risk of developing ED and also to make sensible, because at the end of the consultation, we need to manage patient. We need to address risk factor, not just to tone down the diseases, but also to change behavior, especially when we talk about therapeutic lifestyle changes. And these are some of the components or confounding factors in relation to erectile dysfunction. And I'm worried the most, especially among primary care, is those social issue, as you mentioned here, sexual activity avoidance, marital disharmony, discordance, poor health-seeking behavior, and so on and so forth. So, as they say, men age like wine. If you look at Mr. Arun is so youthful, energetic. He looks very, very young. But unfortunately, when you talk about erection, it does not apply to erection, especially among elderly group of people. So if you look at this study published in 2023, it is said roughly about 64.1% affecting those who are aged more than 60 years old. So I'm not worried about those maybe 60 plus, 60, 70 plus. But nowadays, on our doorstep, we are seeing young and younger EDs. This is due to, I think, because of the emergence of communicable diseases, non-communicable diseases, addiction, psychosocial stress, and also expectation from the partner. So, lifestyle, behavior, diet. Malaysian, we are blessed with foods, whether you're Malay, Indian, Chinese, we have, even the, Sabah, we have a lot of food, variety of food. So based on our, literature review, we found a lot of mixed results pertaining behavior factor. And if you look at this evidence, those who consume increased number of flavonoid, leafy vegetables as well as fruits, reduce the risk of ED. And good news, those who are taking high Mediterranean diet, especially your nuts, legumes, seeds, and low consumption of red meat and oil or fatty food, reduces the risk of developing ED. So how about physical activity? We know that it is good for our heart and also for the penis. So if you look at here, moderate intensity was associated with lower odds of ED compared with no physical activity in a week. And also good news for our diabetic patient, we can advise patient in order to avoid or to reduce the risk, we can motivate our diabetic patient to have exercise. And Based on our finding also, cyclists had higher odds of having ED compared with non-cyclists. So these are the the group of people that you need to counsel the patient, to go to a sports physician specialist to measure their bike and, saddle and so on. So obesity, we know that 50% of Malaysian fall in the category of obese, and we know that obese had higher risk of ED compared with non-obese, 78% higher. This is because of a lot of things. Insulin resistant, you talk about other concurrent medical issue, polypharmacy, OSA, and many, many more. So when we talk about smoking, alcohol, drugs, as usual, cigarette smoking is the #1 issue in Malaysia, even though we are seeing dropping numbers of prevalence of smokers in Malaysia. However, it exhibits those response. For example, those who smoke more will have severe form of erectile dysfunction. So if you look here, light to moderate consumption of alcohol showed beneficial effect of the risk of ED. It is said that alcohol has this property of vasodilation, and amphetamine, cannabis, opioid, ecstasy had increased risk of ED due to endothelial dysfunction, which disrupt the production of nitric oxide, which is a very, very powerful fuel for our process of vasodilation and erection. So how about diabetes mellitus? So we know that 1 out of 5 Malaysian have diabetes, and if you look at the overall prevalence, this based on this particular study published in 2017, they said that 59.1. So if you look at previous study, up to 90% have had some form of erectile dysfunction, and this is a very, very powerful fact for you to sort of like advocate or advise patients, saying that 9 out of 10 men have some form of erectile dysfunction, so you need to control the sugar level. You need to do something about your A1C to reduce the risk, not just talking about your erection, but as well as other cardiovascular diseases. So it is said here, odds of prevalence compared to diabetic versus health control is 3.6 higher, to develop ED. So how about cardiovascular disease? Yeah, it works, hand in hand. We know that anything affect the vessels, especially the endothelial function. It affects not just in terms of erection, but also other cardiovascular diseases. So hypertension was a risk factor, and it's slightly, the odd ratio of developing is 60% higher. And if you look at ischemic heart disease, up to 90.4% of prevalence rate. So how about end-stage renal disease? We know they are a bit complex when you talk about pathophysiology, you talk about endothelial dysfunction, you talk about arteriosclerosis, hypogonadism, usage of medication, your beta blocker, your diuretics. And when we look here, the overall prevalence was roughly about 71% in this study. And these are highest among those pre-dialysis as compared to HD patient, your PD patient, and renal transplant patient. So how about hyperuricemia? So hyperuricemia is associated with, we know that it is a chronic inflammatory condition. Already developed all these radical oxygen species, and it can also disrupt the endothelial function as well. So was associated with risk of ED, and we know that allopurinol reduces the risk among the patient and also able to reduce the IIF score. So the prevalence of ED among OSA is also quite high, alarming high, roughly ranging from 40.9 to 80%. And also chronic prostatitis or chronic pelvic pain syndrome had also high risk of ED compared to non-chronic prostatitis patient of a ratio of 2.6. So how about depression, anxiety? We know that those depression patients have lower form of serotonin. So in this particular study, depression had higher odds, roughly about 2.5 higher compared to non-depressed patient. And we can see, especially those young patients present to us with, this performance anxiety, they have higher chances of developing erectile dysfunction. Instead of focusing of their partner, of themselves, they focus on their partners. So how about antihypertensive? Yes, we used to blame on all this medication. We talk about beta blocker, diuretics, However, when you look at a network meta-analysis, show there's no differences between a comparison of all major antihypertensive classes. So if you look here, nebivolol had beneficial effect because of the vasodilatory effect compared with non-vasodilatory beta blockers. So how about statin? We worry about, statin-induced Alzheimer's, statin-induced diabetes, statin-induced ED. However, based on our literature review, there's no whatsoever association between statin and incidence of erectile dysfunction. So how about our 5-alpha reductase inhibitors, especially used for your BPH as well as alopecia? So based on previous study, it increases you compared to finasteride versus dutasteride. And if you look here among patient, but no association between this, right? However, a recent meta-analysis has shown that no significant difference in developing ED between finasteride and dutasteride. So how about psychotropic agents, especially antidepressant and antipsychotics, are among the risk factor for drug-induced ED. We know that once you give patient on SSRI, they have some form of low libido because it increases the serotonin and also reduces the dopamine level, which causes HSSD, which is hypoactive sexual desire disorder, and eventually lead to erectile dysfunction. So I mean, we've learned so many things here today. So my advice here, we need to address the risk factors, because not just in terms of reduction of the risk to develop ED, but as well as treatment purposes. So risk factors for ED, including aging, poor lifestyle behaviors, underlying comorbidities, and certain medication. All right, thank you.